For our final address, I am absolutely delighted to welcome Dr. Aletha Maybank, who is the inaugural Chief Health Equity Officer and Vice President of the American Medical Association. At the AMA, Dr. Maybank ensures that health equity is embedded in all of the work of the association, and she will oversee the launch of an AMA Health Equity Center. Today, we are honored to have you here, Dr. Maybank, and for your address, the impact of racism on public health. As a reminder, please type your questions into the Q&A box, and we will have the opportunity to speak with Dr. Maybank after her presentation. Thank you very much.
Hello, everyone. Good to be with you, Dr. Aletha Maybank. Thanks for the opportunity to speak with the Oregon Medical Association. It's been really great to get a lot of feedback and kind of excitement for the Center for Health Equity from medical associations across the country. And we at the Center for Health Equity are definitely here, to work to support the associations kind of moving through this process of what it means to really center equity in the work that we do, whether within the context of the association, but also the work that we do in our healthcare spaces. So good to be with you. Next. I have no relevant financial relationships to disclose. Next. And, our goal is, really to discuss the role that we have as institutions in fostering and exacerbating racism and inequities, but also what do we do in order to mediate them and kind of have a path forward in which we can change the existing realities. Next. So I first start off always, I think this is an important part of anti-racism work and centering equity, or centering those who have been most marginalized in this country and often were stripped of resources and opportunities without their input, clearly without their consent. And so really recognize the indigenous people of this land who were here well before many of us, well before the founding of even this country, and for their thriving and surviving to this day. And then also honor and recognize those ancestors who have been brought to this land and who were forced to this land from the continent of Africa for the sake of for free and cheap labor in order to build and sustain our country and our system of capitalism. These are med students in Tulane. This was in 2019. They took this photo in front of a plantation down south to really honor and recognize that they stand on the shoulders of those who have come before them and who have fought injustice for hundreds and hundreds of years. Next. So just to ground us so that we're all on the same page, important to know, this is a definition of health equity. There are many definitions of health equity that are out there. So this is just one, and this is more outcomes based, but I usually say that in order to have health equity, you have to have the conditions, the resources, opportunities, and power. Power is a really important part of being able to achieve optimal health, being able to achieve a lot within this country. And if you don't have power, if you're not in a position of power or stature, or a state of power within this culture, in this country, it's really hard to achieve optimal of many things. And this is a very simplistic way of defining the distinctions between equality and equity, and really recognize the realities. And our goal is really to remove these structures and barriers that prevent all people from having freedom to live their lives and to be able to achieve optimal health. Next. Important to this conversation of advancing equity is the importance of moving upstream and appreciating public health. Many folks who have heard me speak, I talk a lot about the divide of public health and healthcare, and I think during this time of COVID, it really sheds a light on the need for us to come better together as disciplines and to value and respect what each discipline has to offer to creating health within our communities, but especially public health. I mean, the reality is that we know that health is shaped by many factors and conditions within our society. And our healthcare system oftentimes is focused very downstream in terms of, what's happening in the hospital walls and the doctor's offices. All very important, we know this. However, it's very difficult to fully take care of a patient in many parts of this country, whether urban or rural, if you don't understand the context of which folks live. And so it's important that we do understand the living conditions and the social drivers that impact health. It's important that we understand what are the structural drivers and the institutions and the policies and the laws that actually determine what those living conditions are going to be. And then in this country and in any country, we have to look at what are the real root causes of inequities? What are those lenses that are being used to develop laws and policies that are impacting the living conditions? And we have to look at the systems of power in this country, which are really rooted oftentimes along the lines of those that are listed on this slides of white supremacy, classism, racism, sexism, homophobia, ableism, and xenophobia. So this is the full frame of health, and I don't feel we can advance equity unless we understand this and we embrace it. Next. Important to know that this is not work just about diversity and inclusion. There are lots of conversations, and I'm sure many of you have heard about diversity and inclusion. I think there are very important values and realities that we need to have in order to advance equity, but they alone cannot get us to the point of having equity and justice and fairness. We need to move our conversations beyond just diversity and inclusion. As this great quote rather from that was actually published, this is last week in an article, that we first should demand inclusion and power in our programs of, and it could be health or healthcare, if for no reason other than our basic civil rights. Let us stop with the cultural competence and diversity and inclusion jargon, and really name, these systems of power that are excluding folks from these opportunities. Next. We have to understand, to the point I mentioned earlier, also what produces in health inequity. So I talked a little bit before about kind of what's the frame of health, what creates health for us and for us all. All of those conditions are important for us all that I had on the previous graph or two slides ago. But you also need to understand like what produces the inequities, and we have to look at, again, those isms and those structural determinants of health. I really point out on this slide, on the bottom half, it's important that, folks understand, especially in the healthcare context, there's lots of use of the word social determinants of health. And, I tend to use it less now because it's become very jargony, and it's not well understood. And the reality is that most of what we're doing at the healthcare system level at this point in time is really focusing on the social needs and understanding what are the social risks for people. So we're responding to those immediate conditions as it relates to possibly food or transportation. That's what we're focused on in the healthcare system. We really also need to focus and be able to look more upstream and kind of what is happening within the context of communities in which people live. What are those social drivers that are impacting inequities? And then eventually we have to go even more higher upstream and look at the causes of the causes, as I mentioned before. What is the socioeconomic political context and structures that actually, drive inequities within this country? And as a healthcare community, we have a role that we can play in absolutely all of these levels. Next. So we know that in this country, there are life expectancy differences. So I'm going to move into just highlighting, a little bit of data. I'm not a data heavy person for many reasons, but I want to illustrate a point, is that we have life expectancy gaps between neighborhoods among the 50 largest cities in US in this particular graph. The one with the greatest life expectancy difference is actually Chicago. That's where AMA is headquarters, as you all know. And they have a 30-year life expectancy difference of up to 30 years between Streeterville, which is like the central part of Chicago, and the south side. And it's unbelievable and unjust. And this was happening before COVID even existed. So the question we have to ask is why? And who's living in those neighborhoods? And when you go to look at the data of who's living in those neighborhoods, they're predominantly Black and brown communities, predominantly Black and Latinx communities to be more specific. And again, it's not, it should highlight that these realities are structural. Something created it, something produced it, of why the communities are laid out in this particular way. And the only thing within this country, that can really produce these types of structures are policies, or these types of patterns, rather, are policies. And policies within this country have dictated where people can live, what they have access to, what they don't have access to, whether their neighborhoods are invested or they're not going to have investment, whether they have good transportations or not good transportations, whether they have to go outside of their neighborhoods for jobs or they can stay inside of their neighborhood for jobs. Do they have good agriculture? Do they have grocery stores? Policies are what dictate this. And the reality is that many policies in our country historically have excluded Black and brown folks out of the opportunities to achieve anything that is optimal, as I mentioned earlier. And historically, the specific policy that really excluded folks and determined where they could live are policies related to redlining, which is the map on the left, which is a very old map, but health inequities kind of overlay even these old maps until this day, in which those red communities, they were actually on policy that said that banks should not back loans for families that live in those neighborhoods because they were considered risky. And so it really prevented Black, brown, immigrant communities from being able to tap into that, quote, American dream that has been put out there. And it's really been more of a myth, honestly. Not everybody has been able to really capture or be a part of that American dream, because if you can't buy real estate within this country, it's really hard to tap into that. So only if a certain segment of our population had the ability to be able to buy homes and move out to the suburbs, of why they're so homogeneously white in this country, and everyone else was pretty excluded. So next. And looking at specifically, again, COVID, in terms of a narrative, and I'm trying to kind of break through some narratives about people, there was lots of conversation about early on, the reason why Black, Latinx, and Native Americans were more likely to have and die was because they had these underlying medical conditions of diabetes, hypertension, obesity, and heart disease. But that wasn't really the full picture, as many of us know at this point in time, that, we had to look and understand that the reason why these communities had more COVID is because they had greater exposures, based on the kind of jobs that they have, based on the overcrowding, maybe possibly in the housing that they had, lack of running water in some communities and Native American and Indigenous communities, low wealth, and forces folks to have service jobs. So we have to look at more the structural and social drivers that produce inequities, that set up the conditions that create these higher rates of diabetes, obesity, and hypertension. And the reality is, a good friend of mine says, who's head of the National Birth Equity Collaborative, is that race is not the risk factor here. Race is a social and biological, and I'm sorry, race is a social and political construct. It is not a biological construct. And we have to look at the system of racism and the impacts that racism, sexism, all of the isms have on people's health and their lives. Next. And here's just one last map of just showing, of an old redlining map. You can, and that's the kind of the Black, they don't show up so well, but the red lines areas are the Blackish areas on this particular map. And the bright areas of red are where the lowest life expectancy is happening within the city of New York. So you can see that even though, these decisions were made almost 100 years ago, they still have tremendous impact on what is happening within those neighborhoods at this point in time and the access to resources. And just real quick, a definition of racism is that it's a system of power and oppression that structures opportunities and assigns value based on race. It's a very important part of the definition: structures opportunities and assigns values based on race. unfairly disadvantaging people of color while unfairly advantaging whites. And it really falls along the line of the myth of hierarchy based on skin color in this country. And there are 4 levels of racism: internalized, interpersonal, institutional, and structural. And these systems and this system has been around for, since this country was really founded, or since colonizers landed on this land, actually. We have had a system of hierarchy and power that has disadvantaged and excluded folks. And I think this is important to understand that really we've been in a country that has been under that lens for hundreds of years. And we've only really been in a new period of legalized freedom, represented by the green part, for a very short period of time. And we all understand that legalized freedom does not really even mean freedom fully for people. Next. And also I think important, in understanding the context of production, and I mentioned it a little bit just a second ago, is looking at the effects, really, and this is a global phenomena, of colonization and its impact, the lenses of which it brought of power in order to sustain and to build more power and production over time. And so colonization has definitely helped supremacism flourish, as well as capitalism flourish over time. Next. And so many of us, we say that structural racism, and we know at this point in time, is really the fundamental cause and the root cause of why these inequities exist in this country. If we look across the data at health outcomes, the greatest gaps occur along race than any other demographic that exists. And that's why there is such a focus on racism, because it is a leading determinant of health inequities within this country. And it plays out in many different forms in terms of the structures that exist in this country. Next. So in 2018, the American Medical Association, as many of you know, passed policy that was going to create an organizational unit to focus and center our work on equity. Thanks to a task force that was convened over the previous couple of years. That was their recommendation. And in 2019, when I started, Dr. Madera, as you all know, made this announcement at the annual conference that, what has become clear is that inequities that persist throughout healthcare present obstacles to achieving our goals. As a nation and as an association, we need to ensure that when solutions to improve healthcare are identified, the positive impacts are recognized by all, that one shared characteristic of such solutions is that they are also bend towards health equity. So we have been on a mission and lots of action to kind of move our AMA in this direction. Next. So what's been really helpful for me and my team is that Dr. Madera, who is the CEO, thought through the strategic work and kind of figured out, what does it look like to have these cross-enterprise accelerators, and where does equity sit in all of this? And it's quite clear to all senior leaders and to staff, because this has been communicated quite often now to all staff and the management team, that equity is a cross-enterprise accelerator. If you hit next. Next. And there you can see equity. Next. So equity, is, along with innovation and advocacy, a cross-enterprise accelerator across the 3 strategic arcs, but also folks know it's also with the foundational components of the work that we do as well. Next. So we have come and we've created, our vision and mission, and we have 5 approaches of which we are looking to do our work. And we're hopes to have a strategic plan fully kind of launched or distributed later this fall that really will speak to how AMA is going to be centering equity in the work that we do. And so the first one is just embedding equity, and I'll talk a little bit more about that. The second is building alliances and sharing power. ensuring equitable opportunities and conditions and innovation for marginalized and minoritized people, pushing upstream, which I've talked a lot about already, to all determinants of health, and creating pathways for truth, reconciliation, healing, and transformation. Next. So I'm going to speak to embedding a little bit because I think this is an important part and really where we have to start as associations in the healthcare space. So Alice Walker says, we will be really misled if we think we can change society without changing ourselves. Next. For that, there's an important inside-outside strategy in order to do this work. I do not feel we can do health equity work on the outside or with other folks or in partnership or in our systems if we don't look inside our systems. If our staff don't even understand what equity means, how biases show up in the decisions that they're making, whether it's good intention or not good intention, it's understanding that impact that those decisions can have. And if we don't understand that or how to unearth or know how to unearth that, then we were just going to continue and perpetuate the inequities that exist at the institutional level, which will absolutely have impact in the community and the neighborhood level as well. And so we need to look at all of these internal structures that we have, most of us have within our organizations, and there may be more or others, that impact our policies and our program services and research as well as our culture, and work to change them so that we can have impact. We can become a multicultural racial justice organization that's able to work towards improving health outcomes and closing gaps. Next. This is the model that we're using, and we're working with Race Forward, which is the largest organization doing racial justice work in this country. And we're working with a model of normalizing, building a shared analysis and operating with urgency. Oftentimes, one of our biggest gaps to talk about power and privilege is that we just don't even have a shared understanding of what that is and our analysis, and we can't get on the same page to have these conversations. So it's a lot of kind of capacity building, training, skill building, and then organizing at an institutional level, really understanding where the champions are and where the drivers of change within an institution are, so that we can push forward much faster. And then operationalizing, recognizing that we, one, have to collect data on all the work that we're doing as it relates to this, but also that folks need help. They need tools in front of them so that they can challenge their mental models that they are making on a day-to-day basis. And all of this they have to be able to visualize, and we have to help support. What does it look like? How do we see things that we don't even know exist? How do we know what we don't know? That's sometimes the biggest challenge of doing this work. A lot of this work, and I think I've alluded to this a little bit, is really challenging dominant narratives. So as we're normalizing, we can't do that if we don't understand how narratives shape our consciousness and how we understand and explain the world, and also how narratives and dominant ones can really obscure power and responsibility. That's the point of which decisions are made. Most of us know this, but we don't connect those dots when it comes to talking about health inequities, whether it's by race or gender, sexual orientation, or ableism. That it's about power. Who has the power to make decisions? Who has the power to exclude folks from a conversation or from a decision that's made? Next. And in this country, there are several dominant narratives or myths, you can also refer to them, that undermine health equity. And we hear this somewhat in the headlines, that race and class inequities are unfortunate, but not necessarily unjust. That self-determining individuals make right or wrong lifestyle choices. So a lot of blaming. So that's what happens when you focus, and this happens in healthcare a lot. You focus so much on the behaviors and the risk factors without understanding the social context. What is driving the reasons why people have to have certain lifestyle choices? We totally miss the mark oftentimes of really trying to remedy why a person is getting sick, why a person has a chronic illness, why a person we feel is not following our instructions, because we're placing blame on those lifestyle choices and on the person oftentimes themselves, and not looking more upstream and understanding more upstream of what's not present. that will allow the person to make the healthiest choice. And oftentimes those have been rendered invisible, or they're ignored, even if you know that if we look at our own lives, I mean, we should understand that when you're in a space of privilege, a lot more, but it really goes out the door oftentimes. There's a lot of othering. We see that in the country today all the time, blaming other people for why they have poorer health outcomes. Picking yourself up by your bootstraps, the meritocracy, the myth of meritocracy. There are many people in this country and folks who have not had the opportunities to live in communities that are resourced and invested. They work hard, and they could work as hard as they want. It doesn't mean they're going to achieve the same amount of wealth as someone in another community that, not saying that somebody else hasn't worked hard, but when you have generational wealth passed down, it is much easier to acquire and to continue to acquire and accumulate wealth in that way. And we know in this country, whites are 10 times more likely to have wealth than Blacks in other communities. American exceptionalism also undermines health equity. The zero-sum game, or the myth that if you gain, I lose. And then I already mentioned the hierarchy of human value based on skin color, white supremacy. Next. And what's important about those myths actually is that I first talked to you about kind of the technicalities of how we're going to do the work. So the inside-outside strategy, we have a model that we're employing, we're doing training, we're utilizing surveys, we're going to create tools, but those are the technical pieces of the work, and it's important to do that. But if we don't shift the values, if we don't shift our critical consciousness to understand these values that undermine equity, it's really hard, even with all the work that we do on the technical side, to really advance equity. So part of this work is absolutely understanding and digging into our power and privilege. And this can be based on race, but it can also be just on, incomes that folks have and the stature. Being a physician or a healthcare worker oftentimes does create privilege in a way that can disadvantage others without us even recognizing it. So we have to recognize these in many different facets. Next. Our bias and our blind spots. Lots of conversation around biases, especially implicit bias. I'm a person who tends to shy away from saying whether something is unconscious or implicit, because I think, again, or if something's good intent or not good intent, a lot of folks can have good intention and great intention. The reality is that intention, we have to look at what is the impact, because if that great intention has bad impacts, then we need to change what we're doing. And that's what we have to focus on. Next. And we understand there are all these demographics that exist, and identifiers, and ways of being that we all connect to as it relates to race, gender, sexual orientation, language, culture, ability, and age. But when we're talking about inequities, we have to, again, look at the systems that are producing these inequities as well. Next. So we have to reframe and look at sexism, racism, classism, exploitation, ableism, and social exclusion. We have to look at these and assess these and research these systems and how they impact health. So one of the ways in which we have built in accountability, actually really early on, this is, if you look on the left, the whole point of this is that we have what we call performance goals or performance measures. Most staff have them, most employees in different places have them, whether tasks and standards, or we call them APEX. And all employees now have to include health equity work in their objectives and standards. And the performance factors included in everyone's APEX form now will include specific behaviors that support health equity efforts. So for a certain percentage of folks who are really involved in kind of our health equity work group and our action teams, they'll get awarded a little bit more for their participation, and then all other employees will also have a weight for doing health equity. So there's accountability for all employees now to do health equity work, and we're making sure we find and identify those opportunities that employees can participate in. Next. And then lastly, just in terms of the inside-outside structure, is operationalizing, which I mentioned, and the key question is, how do we ensure our efforts and innovation do not discriminate, exacerbate inequities, or deny care? So there are a set of questions that our staff and our teams can ask themselves as they are developing programs and plans, policies, research, systems, flows, quality improvement opportunities that they can ask themselves as they're doing it, to make sure they're asking all the questions they need to ensure that they're advancing equity, like who benefits from and who will be burdened by the proposal or the suggestion that is put forward, and being really thoughtful and intentional in identifying that, and not leaving it to, yeah, you know, I definitely care about this, I care about inequities and all of that, but that could be great, but you could also have unintended consequences because you weren't really specific and intentional. Next. So lastly, as I kind of shift into the next phase of this talk, again, I talked lots about kind of the technical parts of it, but I really like this quote, and I think it's very important, because the reality is that we always have to remember that these inequities, the power, the privilege, the racial justice, all, you know, what we're talking about, health equity, many folks can disassociate from the language that we're using, social determinants of health, etc. But we have to always remember, and the last sentence says, you must always remember that the sociology, the history, the economics, I would say the medicine, the graphs, the charts, and the regressions all land with great violence upon the body. And that's the reality, is that that these systems are violent upon people's bodies. They cause stress that's chronic over time. Next slide. They cause stress that's violent, that's chronic over time, that impacts our stress hormones and elevates them, and then further impacts and creates havoc upon the body, leading to higher rates of heart disease and all types of disease. And then even over time can evolve the expression of our genes that can, and this can be passed down across generations. And there is plenty of research and evidence on this. And it's not just racism, but really, again, all the forms of isms that I mentioned before have actual physical impact. Next. And this is why, you know, racism is deemed as a public health issue, and why it's a public health threat. It doesn't just happen to the individual, it happens to communities, and it can be passed down across generations. And so this past summer, AMA, as many of you probably know, put this statement forward, and that we oppose all forms of racism, that it is an urgent threat to public health, and that we will do and actively work to dismantle racist and discriminatory policies and practices across all of healthcare. A pretty bold statement. And I think what folks are definitely waiting for is to make sure that we all have actions that are going to support a statement such as this. Next. And, you know, I mentioned some of the work that we're doing, but I truly believe that we can't really do this anti-racism centering equity work without really assessing our own institutions' history, present, and practices. And that's in our associations, but also within our healthcare systems that we work in as well. There aren't many systems that are historically white in this country that do not have an experience of which there was definitely power kind of pushed upon communities of which, the neighborhoods of which they're serving, that caused, whether it was bad health outcomes or just bad outcomes, and had some negative impacts. And so we really have to dig into what are those things that we did in our history. And so these are, many folks are aware of our exclusion of Black physicians, and then the impact of the Flexner report. Many folks, I in my kind of being at AMA, don't talk about that as much, but there's definitely more push from the outside to really elevate the impact of Flexner. While AMA is, you know, many folks have said it has been a great thing in terms of creating much more rigor among medical schools, feeling that, you know, going towards really structuring basic and clinical science was a great thing. We don't look at the unintended consequences to some level, you know, that when you focus only on clinical and basic science, you've really also, we moved away in medical education from valuing the context of people's lives and the social context of people's lives that also impact their health. And so that needs to be built back into medical education so that there can be an appreciation and value, and then skill set and actions that also support understanding that social context beyond just the basic and clinical science. And then in addition, one of the big recommendations that I don't know if this is intended or unintended, honestly, or unintended or intended rather, but the recommendation of closure of five of the 7 Black med schools actually happened. And so when we talk about the lack of diversity of the healthcare workforce today as it relates to physicians, this is one of the sole and root reasons of why. Next. And this is the Flexner report again. There was a recent JAMA article that actually looked and analyzed in a very interesting way that if those 5 of the 7 were still open, there would be 35,000 more African American or Black physicians to this day, and it would have actually equalized to some level, or at least had better representation of Black physicians within the physician workforce. So we have to look at that, you know, and not only do we have to look at the numbers and the impact, but what do we have to do as the AMA to remedy the harm that we've caused? Next. We did issue the apology, as many of you know, in 2008. And as Dr. Ron Davis said at that time, that this was not the end, that it was the beginning. Perhaps in the end, perhaps it is, but it is perhaps the end of the beginning. Next. And the work that we have to do that I feel many institutions are now embarking on is under the umbrella of truth, racial healing, and transformation. This is, you know, I started with the embedding part, the technical pieces, which are important. I didn't talk as much about the other strategies that we have in between, except for maybe moving upstream and the importance of doing that. And now I'm really focusing on kind of the truth, racial healing, and transformation in these last couple slides that I've shared with you so far. But we need to kind of elevate and move to that point in order to really transform our society to this day. And I put this on the Black Panther on and Chadwick Boseman, you know, as many of you know, who just passed away, because in order to reimagine a new society or a new way of being, it's going to take a lot of work. And Wakanda, for those who are familiar with the Black Panther, was that opportunity to imagine a community and a society that wasn't colonized, and what would thriving look like. And we are going to have to be able to do that in the work that we do with our healthcare system and in our country overall. And it's difficult because, again, we don't know what we don't know oftentimes. And it's hard to fully imagine what we've never seen. But I think we have to rely on then partnerships and people who have experienced injustice and what they know would be a better life and a better way of living. And how do we have a better healthcare system? People who are impacted most negatively and marginalized by our systems, what to them would look better and be a better system? Next. Oh, and lastly, to close out, talk about our COVID work. Next. We have, you know, done quite a bit. I would say we launched a Health Equity Resource Center, which is online now, has lots of information. We just launched our resource that actually has case examples across the country of different cities or organizations that have been doing work to center equity in their response to COVID-19. We had received a lot of ask and reach out about that, so we wanted to kind of be a central source for that. We're collecting examples every day. We published a paper within JAMA about having a structurally competent healthcare system. So again, moving more upstream, not just culturally competent, but structurally competent and structurally responsive. Lots of information about the missing data and using our voice, which the data is still missing. I just looked at a report from yesterday. So we still have a lot of work to go in that area. And I had the opportunity to talk with Ms. Oprah Winfrey and really highlight actually the AMA Center for Health Equity, but also this work that we're doing on missing data. Next. We launched a prioritizing equity series, which we are really centering the voices of many physicians that often have been marginalized and minoritized in this country, to hear their experiences, but also to talk about what does it mean to prioritize equity during this time of COVID. And it's relevant for COVID, but it's also relevant beyond COVID as well. And this is really really done very well. I think we've done a good job at really having conversations that are very candid. And so I encourage you all to check them out if you get a chance. It's also on our COVID health equity resource site. Next. And we've been working in partnership with In Chicago. This past year, for those who don't know, we went into a partnership with Westside United. One of the first times AMA Chicago headquarters has done something of this magnitude in their own backyard. And so we are investing $2 million over the next 2 years, along with 6 other healthcare anchor institutions, to do work and to support upstream work and upstream opportunities that are listed here to support the community. Understanding investment and money and capital are very important in order for folks to thrive and to be healthy. What happened during COVID is because this infrastructure was in place already with all of these different partners and stakeholders, the mayor was actually able to call upon Westside United to start racial equity rapid response teams to focus specifically on mitigation within the area and to identify and listen to resources and needs of the community. We launched also Release the Pressure is a partnership with Essence brand. That's a well-known brand, probably one of the top brands within the Black community. We understood that, and many of you know, the data shows that folks were not seeking care during COVID time. And so we wanted to find a way in order to engage our communities to still focus on their chronic health needs, provide information about that, but also provide information about COVID. Next. And so this is the last slide to just, doing this work and centering equity takes a tremendous amount of leadership, courage to do, it's courage to speak, courage to listen, courage to be uncomfortable in ways that you may not have been before. And if we're really committed about it, we have to have that experience. And it's really important at this time that we all kind of speak up, use our voice, use our power in meaningful ways that help advance equity and figure out how to do that. Thank you.
Thank you so much, Dr. Maybank, for that incredible presentation. As a fellow Chicagoan who went to medical school at University of Illinois, Chicago, I feel a bit of kinship with you and some of your slides and your perspective. So thank you very much. One of the slides that really resonated with me was in the beginning of the pictures of equity next to equality. I actually have that pair of cartoons hanging on my refrigerator door, but I hadn't ever seen the two that were paired with it, which are the reality and liberation. I think your presentation really charges all of us to move beyond the superficial recognition and really look for action to change that reality so that we end up in that area of liberation where there are no barriers left. So thank you very much. We have several questions that have come in. And so we'll spend the next little bit going through some of those. I think I will start with this one. This comes from a member of the audience. As a white male physician, can you offer helpful ways to enter into conversations with my patients of color to discuss health and equity without the impression of sounding and acting paternalistic?
Thanks for the question. So how I would start that is, I think part of this is just demystifying to some level that we're unable to have conversations with people from all different backgrounds. I think oftentimes we become fearful. There's maybe certain levels of anxiety that people feel because we haven't been having this conversation, or even people haven't been challenged in this way. So there's some assumption that for some reason we as individuals and as physicians wouldn't know how to speak to people. And I really want to demystify that moment, because we talk to our friends and our families all the time, and we know how to connect with them, usually in very meaningful and helpful ways. Most of us do. And I think we just have to approach people in that same way, with a certain level of curiosity, as we're listening and we're talking to people and we're asking questions to just learn more and express, I'm just want to learn more. I don't fully understand possibly, all that you're experiencing. And I want to make sure that, I as a physician is really understanding the context, and maybe not use the word the context, but the situations, within your life, that will help me treat you better as a physician. And that opens the door, and then you ask explicitly, so have you had experiences, lately with any kind of discrimination or racism, or if there's something else going on, with anything related to that person's identity, and just kind of opening the door, but also sometimes being a little bit more pointed and explicit, because we know it does have direct health outcomes for the individual in terms of stress. And I think that's how we approach people. That's how we approach building trust, and just really affirming another person's humanity. That you ask the questions, look at them as a human being, and treat them as such. And then you won't come off, to me, from my perspective, as paternalistic. If you go into that mindset, then you will. If you go into the mindset that something is wrong with that person, or even just pity on that person, oftentimes we can enter a conversation not in the right way. And so that's my suggestion on how to approach those conversations with our patients.
Great, I love that. Approaching with curiosity, just to discover. One of the things that you said is one of your slides was about the false narratives, and these narratives that are perpetuated, and that you describe also as myths. And so I'm curious how we as clinicians and providers in the community, how can we help change the shape of some of these narratives from the people that we are seeing in our clinics and hospitals and other healthcare settings?
Yes, I think first it's understanding more in depth what those narratives really mean and how they play out in our day-to-day lives, whether it's in the context of the healthcare environment or within our own daily lives. And they show up the same. We just use different language, different words, whatever. Or the root is the same, let's put it that way. So I highly recommend checking out. So Dr. Kamara Jones talks lots about the 7 myths that exist that prevent us from ever advancing equity. So I think I mentioned it in the slide deck, of the technicalities that we need to do, but then what's really kind of the value piece that we need to change. So I recommend reading that. And then I recommend really a large part of this work initially, I think for many of us, is that kind of capacity building around knowledge, so that we can begin to build the skills. But you can't, it is really hard for me to tell folks exactly what to do unless you really understand the analysis behind it. And so I recommend books like Cast is a new one that just came out by Isabel Wilkerson, which I'm sure it will win her another Pulitzer Prize. It's a really wonderfully written book. And it really just basically states and does some comparison between amongst the Holocaust as well as India, and stating that we in America have had a caste system from the beginning of time when colonizers landed on the land. So, and it just does a beautiful job at framing all of the contexts of kind of white supremacy and all the forms of oppression, and really rooting it in that the structure around power. And I think when we start to understand that, then there are so many things that kind of open up to us, because reality is we don't know what we don't know. And that's what this work, initially is really pushing for us to see those things that we never really saw before, so that we can appreciate and we can actually do and create and do things differently. It's hard to do things differently if you see things exactly the same. And so we have to push ourselves so that we can change and push our own mental models of how we come to work every day. And so I really recommend as physicians to just really start building that knowledge base. You know, we talk about building knowledge bases with everything else we do, so we have to do it with this as well. And so medical apartheid, which I had, I think, in that slide deck somewhere as well, and is another really just kind of eye-opening book. I was talking to a fellow AMA member the other day that I provide some mentorship to, and he said he was reading the book, and he said he had to stop reading the book because it's really, it's pretty graphic, you know, and it's just pretty horrific to kind of hear kind of the medical community's relationship with people who were enslaved in this country. But it was powerful for him to really get rooted in not only just the knowledge of it, but almost the heart of it. Like, it's hard to move away from the heart. It's just like seeing the public murder of George Floyd. You know, that moved people in a different kind of way.
Yeah. You know, hearing you talk about those two books in particular, and you mentioned the importance of bringing this awareness into medical education, it seems like those two books should be required reading for every medical student, among many others. So I really appreciate that very specific kind of call to action.
Yeah, and I sit on the AAMC now has a committee for equity, diversity, and inclusion. So we're some other folks that you all probably have heard their names if you're into the equity and diversity space. But we're on a committee looking and creating, standards and competencies for medical education, as well as residency and physicians as well.
That's wonderful. We have time for maybe 2 or 3 more questions, maybe only 2. There's so many good ones here, but the shifting gears a little bit, the National Association of Physicians in part started to put focus and support for Black and other non-white physicians because of the treatment by AMA. And so the question is, are there discussions now between these and other physician organizations serving other clinicians of color to do a better job of collaborating and doing so collegially?
Yeah, so that's exactly the second strategy that I mentioned, the building power and sharing alliances in ways that we haven't before. And it's completely acknowledging the strengths and the assets that the National Medical Association, the National Hispanic Medical Association, GLAMA, you know, all of the organizations that are there. How can we better work with them so that our partnerships are more meaningful, and meaningful meaning, shared decision making, et cetera. And some of that, you know, may mean as AMA, who's a little bit more resourced than many of these organizations, that we're willing to share our power in terms of resources and financial resources as well. And what does that mean and how does it show up? So that's, you know, we're thinking through opportunities as that, but I think it's absolutely critical that we have partnerships with physician organizations that even also are not even in the fray or like in the usual kind of suspects per se of organizations that are engaged in leading in medicals or organizing around medical medicine rather. There are other organizations that oftentimes don't get elevated or don't get as much attention that I think is really also important to connect with as well in this country. And then we're working also with the Federation. So clearly we're, you know, in communication with the medical societies, but also the other physician associations across the country. And we work very closely with AAP and AAFP, and the plastic surgeons have reached out for us to, you know, speak with. So it's, you know, and, you know, I smile because, you know, I just, sometimes we don't think that, you know, well, that's my bias. So I recognize that as my bias, that surgeons would be fully engaged and interested, but they're human beings as well and have been moved by all of this. So it's been just really pleasing to see how many folks have reached out, you know, across the physician community to get more information and to learn more and to figure out what to do and how to do it best moving forward.
I know we are close to running out of time, but I do want to just give you the opportunity to answer one more question, which is, You talked about making change on the outside and on the inside, and I'm sure that there's people in our audience today who are really curious to hear your advice about what are the one or two things that I as an individual can do to help move all of this forward.
Yeah, I think what I mentioned before, thanks for the question, about just one, learning as much as you can. Because you get comfortable talking about this context to our society and life, the more you embed yourself in it, as with anything else. I can't say, maybe 10, 13 years ago that with an institutional setting that I would be fully comfortable with. I have to get my charger, hold on, sorry. My computer's gonna die. I don't want that to happen. I wasn't fully comfortable, when I first started doing this work, to say racism or white supremacy in all audiences, but I'm very comfortable in doing it because I practice it so often, I do it a lot, but I also know the facts behind it. It's our science and our evidence that leads us there. And so once we really start to understand that, then we gain comfort. And we need to have that comfort, because if you don't have that comfort, then it's very hard to speak up when you're in meetings or your environments and you do see something wrong. You kind of can get uncomfortable to speak up because you're like, I don't have the language and the words behind it. I don't know how to talk about it. So I think those are the two things that we need to do, is learn and then be able to speak up about it, and then be able to act, and you can figure that out not by yourself, but other people who are allies and accomplices, in your space and in this work. And so lean on each other within your systems and organizations to do this work collaboratively.
Great. Thank you so much for joining us today. I really hope that our paths cross again.
Yes.
And I wish we had more time for questions, but we appreciate you taking the time today, and hope you enjoy the rest of your weekend.
All right. Everything. Thank you, and same to everyone else. All right. Bye.
Thank you.